All right, I think hopefully we've got a critical mass. We'll probably have a couple of other folks join on. We don't have too big of an agenda today, so um, we will go ahead and get started. Happy New Year. It's February, so I probably shouldn't be saying that anymore, but this is our first meeting of the Trauma Administrators Committee in 2026. So I will say it, and this will be the last time that I'll say it, but welcome. I hope everyone um, had a great holiday season and this crazy weather that we're having. It is interesting right now. But all right, first item up is our approval of the meeting minutes from November. Those were sent out. Hopefully, everyone had an opportunity to review those minutes. Let us know if there are any corrections or edits needed, but otherwise, I will take a motion to approve the minutes.
This is Damien. I'll make that motion.
This is Pam. I'll second it.
Thank you. We have a motion and a second to approve the November 3rd, 2025 meeting minutes. Any questions or discussion? All right. Does anyone not approve the meeting minutes? We'll do it that way. All right. Sounds like we are all in agreement. I will document those minutes as being approved. Thank you very much. Next up, we have our Georgia Trauma Commission update by Liz.
Hey, good morning. Thank you, Dr. Walker, and good morning, everybody. I'll keep the updates brief this morning so we can get into our other two items of the agenda that I think will take a little time. The only updates that I wanted to share with this group are, of course, we are in our first couple weeks of session, and the commission will consider the budget for the FY 2027 year. I'm happy to report that the extra 4 million remained in the governor's recommendation. So now we just have to keep our fingers crossed that it survives both the House and the Senate processes, and then the Joint Appropriations Committee. I will say that I was very pleased that the House Health Appropriations started their budget preparations very early this year. In fact, we went up to the Capitol in December and did probably about a 25-minute presentation. So they were able to hear a lot more than they usually are, as those meetings are very time constrained. So we really got to talk about our agency, some of the pain points and some of the things that we're looking toward in the future, and potential barriers and issues. So that was extremely helpful. As far as meetings go, we have our winter meeting coming up later this month. February 19th will be the commission meeting. The GCTE is also meeting that day, as well as the medical directors, correct?
Yep.
And then anybody else? It's all compressed on my calendar.
Yes.
And then GQuip meets the day after. So that will be the smaller meeting, and that is the closed meeting, so that they will talk, they will consider review unblinded data and do some case analyses. So excited for that coming up. And then we are knee deep in the readiness cost survey. So thank you again. I know we got a lot of questions this time. Gabby gathered some really good feedback, of which we will share with all stakeholders. I know there were, each iteration of this, we learned so much, and this year's analysis is no different. A lot of take homes, a lot of things to bring back. And one of the big things is that we noticed we just need to give you guys some clear direction and formulas, particularly as it relates to the subspecialty provider. I think that was one of the most challenging costs for all of you. But I think we're in this kind of strange dichotomy here, where some hospitals either employ physicians and some hospitals still have private practice physicians. So both of those scenarios sometimes make it a little bit challenging to tease out your trauma related costs for those services, but we're trying really hard to figure out a way to streamline it. And I think that's all that I have, unless there's any questions. And Dr. Walker, I know Damien is on the call, and he might have a couple words to add around the funding piece, Damien. It's might be a good time, if you're okay with that, Dr. Walker.
Yep.
Hey, good. Thank you, and good morning, everybody. I'm Damian Scott. I'm the CEO at Emmanuel Medical Center. Like a lot of level 4 trauma centers, I also serve as the trauma administrator, and um, we love being part of the trauma system. We love being a level 4. We think we actually provide tremendous value to our community because of it. Unfortunately, we've seen a massive uptick in uncompensated care costs at Emmanuel, so it's really making us having to hold every dollar up to the light. And so we unfortunately are really at a point where we're having to, question whether this is something that we can continue. It has me deeply concerned because I remember from our when the American College of Surgeons came out, they felt like that our rural system, the trauma system, was fragmented and underfunded for rural. And so I just that just has me scratching my head because I was also speaking to several of the CEOs, which are in the southeastern part of the state, and their response was, "There's no way on earth they would even remotely consider trying that," and most of it was from a resource um, and a readiness. And I just think if we it's just something that's just been on my mind quite a bit. How can we not only how can we strengthen the level 3, level 4s, and perhaps even expand into some other parts of the state where we see it's pretty easy to see when you look at the map that there's some gaps. So I'll be meeting with the Trauma Commission to share some of my ideas and concerns. But Liz, thank you, and team, thank you for just letting me voice them here as well.
Thanks, Damien. Appreciate that. Dr. Walker, if there's any more questions, I'll turn it back over to you.
Okay. Well, Damien, I really think your comments actually segue into the rest of what we wanted to spend some time talking about today under new business, although it's kind of continuation of a conversation that was started previously because the RMOCs, the Regional Medical Operations Care Coordination Centers, um, as we think about how we might develop that for the state of Georgia, then there may be some utility with the RMOCs and supporting those rural facilities, those 3s and 4s. I don't know. I'm just throwing that out there, but certainly something to think about as we consider what might an RMOC look like for Georgia, and how could it support what we're already doing and fill in some of those gaps that we have, not just around emergency preparedness, but really how do we use it in our day-to-day operations to help all of us be provide better care to our organizations, or to our communities rather. So just to jog your memory, of course, back in November, Dr. Benji Christie came and presented to this group. He presented, and so I'm looking off to the side because I have my notes over here. So, and he presented during that committee meeting on trauma system readiness in response to some potential national security threats. And oh my gosh, think about all the things that have occurred since November that really, I think, make me appreciate even more how important this body of work is. Not to make this a political, comment or statement. I'm just want you to think about it from a factual standpoint of the things that have happened, in the last several weeks to 2 months that have really affected us all. I mean, I had coworkers that had gone out of the country over Christmas and were stuck for a little while because of the situation with Venezuela. So, I mean, these things are happening as we speak, and the onus is really on us to make sure that we are thinking ahead, thinking about the future, being prepared for it so that we are not reactive, that we've already put the work in to make sure that we can take care of our our patients in our communities. So at the November Trauma Commission meeting, we did have some further discussion about the RMOC and some of the work that's being done with the trauma medical directors. And I also talked about the fact that Dr. Christie had come and that the trauma administrators are also interested in supporting the work. We're just not exactly sure what that looks like. So at the trauma medical directors meeting on the 19th, I've been invited to come to listen and hear some of the work that they're doing at that level, but also I will be able to kind of bring the administrative views into that venue. And so I didn't want to go in just assuming I knew what you all thought. And I have developed a very brief survey that we're actually going to do during the meeting. So you do not have to, it's not going to get sent out or emailed out. I mean, I guess we still could, but if we've got enough people on this meeting, we're just going to go ahead and do the survey right now, real time, and then kind of review these results. So it will take you, it's what, seven questions. It will take you just a couple of minutes to go ahead and do. So you'll get it over with, and then we'll kind of talk about these questions. Theoretically, I would love to kind of maybe get a subcommittee, an RMOC subcommittee that can kind of spearhead this, but wanted to just get a pulse check from the overall committee, and then we'll kind of go from there. So if you could right now go ahead and scan the QR code. I know some of you, at least one is driving, so understand if you're not somewhere where you can do it right now, but for those of you that can, if you'll go ahead and scan the QR code, and then we'll take a few minutes to go ahead and do the survey.
I also put the link to join on the meeting chat if the QR code's not working for you. And once you scan it, you should see the screen that says you're all set. And then we'll just give everybody a couple minutes and we'll progress to the next slide.
All right. Hopefully, has everyone scanned it? It will say waiting on presenter until we proceed with the slides. So that should be what you see.
We ready to progress, Dr. Walker?
I think so.
I think we've got the majority, 25 out of 30 responded.
And there is a trend.
All right. Yes.
Do you want to continue to the next slide or
I think
discuss?
so. Is anyone still, well, I guess we can go ahead and discuss. So clearly, sounds like the bulk of folks are not very familiar with the National Trauma Emergency Preparedness System revisions that include those RMOC frameworks. So there's some educational components that certainly may benefit us all. Next question, how important do you believe RMOCs are for Georgia's trauma system readiness?
That's somewhat of a challenging question since most of us weren't familiar with them.
That's a good point. We'll put an asterisk next to that. I will say these questions were developed by me, so if they're not good questions, then blame me.
What I meant is if we're not familiar, I guess we need to do something. How about that?
Okay, I'll take
It's
that.
important because we need to do something, even if we're not familiar with what the something is.
I'll take that. And I see your comment in the chat, Becky. Hard to answer because don't know enough. Okay. Duly noted.
It looks like you got majority participation in this one. Ready to go on to the next slide?
Next slide, yes.
Right.
Okay, this is just any interest in participating in a work group focused on these couple of things: expanding our military civilian training partnerships and developing and implementing RMOCs. Do they have to pick one or the other, or will this allow them to pick both?
believe this is one or the other.
Okay. Because I will say, in a perfect world, I'd love to pick both of these. We have started a military civilian training partnership already at our organization. It's in its infancy, but certainly something we are actively doing, but then also the developing of the RMOCs as well. So I'm hard pressed to pick one of those. If you responded yes to one of them, what level of involvement would you prefer? Either being an active member, regular meetings and planning, being in an advisory role, providing input as needed, or information only, you want to receive updates but don't really want to be actively involved. And again, you're kind of signing up for something without knowing how much involvement and what I'll be signing up for. I know what you all are thinking out there. I got it. I got it. This is just sort of laying the foundation. I don't have an answer yet for exactly what all will be asked of you because we don't really have a plan yet, but this is just trying to get who's interested, who's not interested. Okay, now this one you should be able to select multiple items. Which of the following barriers do you believe are most significant for RMOC implementation? And really, I want you to don't focus so much on RMOC. Do I really know what an RMOC is? I think when you read these, you can really just think about if we were to do some, collaborative effort across the state, what barriers would be most important?
Dr. Walker, I just dropped a bunch of RMOC resources into the chat. One is the ASPR guide toolkit for RMOCs, and the other second one is, and we can send these out when Gabby sends out the email too with the draft minutes, because folks might not be able to, if you're on the road or whatever, you might not be able to grab it from the chat. But the other one is a toolkit that the ACS is working on for the COT chairs. And there's a little direction there. We'll make sure that folks understand how to scroll down and get to where, but it is really helpful to see what the ACS's vision is for this, given clearly that they work very closely with the Department of Defense and in particular scaling for large scale combat operations. And then there's a nice little article on the role of RMOCs in surge readiness. I think it's American Surgeon or JAX might be the journal of the ACS. And so that's a good quick read.
Perfect. Thank you, Liz. All right. And any other barriers that weren't listed? Is this a free text response? Yeah, there's a box here. So if there are things that you think are important that don't fit into any of those other categories, please, you can type that in now. As long as it's 200 characters or less. Oh, it does say you can submit multiple responses though. So it can be more than 200 characters, but you may have to put it in multiple times. Communication, that's popping up here a couple times. Coordination across divisions, requiring leadership from the level 1s and level 2s. Existing capacity is already limited. There's another vote on communication, definitely. Communication is the underlies all of what we do in healthcare. Resources, definitely. Perception of bias of where patients are being sent. Okay, that's a good one. National standards. Fantastic. Keep them coming. Budget and finance, resources. Yep. So some of what Liz put in the chat may speak to some of these national standards. I don't know if we can call them standards yet, but certainly I think there's some information out there, like she was saying, about the ACS and how they're working.
Dr. Walker, one thing I could offer to you is, since we know that some areas of the country do this better than others, and Texas comes to mind, we could potentially have, try to have like a sort of guest for like 30 minutes or something of the next meeting and just ask questions, because I think sometimes just learning from what folks have experienced as challenges and, how they overcame them and what successes they leveraged and things. Sometimes, we think about all the barriers, but we don't think about, well, we've already overcome a lot of hurdles, so how could we leverage some of the existing structures and not make this another layer? I think just looking at it from that lens might be helpful.
Sure. Be happy to. I definitely want to, after the 19th, I feel like after the trauma medical directors meeting, hopefully I'll have a better idea of the other, what other work is going on, around the trauma commission. And then I'll circle back with this group about where I think we best, fit into that. HIPAA impact on real-time data sharing. Okay, that's a good one. And that would be a great one to pose to someone who's already doing it of how do they overcome those HIPAA related barriers. Okay, I think this is pretty good. Is there one other?
Well,
So this last one sort of we almost captured this in the last question. So the last question kind of went along with the previous the one about barriers. This one I was really trying to get at any ideas concerning or concerns, but really more ideas. I know clearly based off of the first question, there's not a lot of knowledge about RMOC development, so I know you may not feel prepared to answer it from that standpoint, but I think I really wanted to more see if people had current ideas about what it might look like. If you've had experience, like Liz said, if I think Alabama is another state that has one. So if you have any ties to another state where you've seen it work, or if you have a military civilian partnership already that you're aware of. So that's what I was really trying to get at with this question. I know it seems kind of redundant now with the last question, but.
I think Pam, Grady has a MilCiv partnership. I don't know if you had anything you might want to mention. I thought I saw your mic unmute.
Yeah, I was actually going to put it in the thing. Yeah, we have a very robust military civilian partnership, and we're actually looking to expand it. We have an embedded AMET3 unit here. We have 2 trauma surgeons that have been embedded in our program. And we are actually adding a burn surgeon hopefully this fall. Or the spring. So they want us, our last site visit, they want us to expand. We do a lot of training with our special forces. And so we're very, very active from a military civilian standpoint. And happy to share with others if they would like to do that as well, because they really want to strengthen what we are doing with our partnerships.
Right. And the military skill sustainment, I mean, that's really what it's all about, is making sure that our military clinicians are, have access to patients so that they can keep those skills up and or maybe gain, new skills so that when they are on the front lines, they are used to doing what they do. Partnerships being impacted by government shutdowns. Oh, that's great. All righty. I appreciate everybody taking the time to do this during the meeting. I felt like that was great because I get surveys sent to me all the time and I really have good intentions. I really intend to complete them, but I don't always complete them by the deadline. So I think taking the time to do this during the meeting is a great use of our time to ensure that we actually get responses and we can have some discussion too. So thank you all. I'm going to take, a summary of the survey, and again, we'll include it in the minutes, but also I'll be able to at least take this at a very high level into the trauma medical directors meeting and just kind of tell them, what our initial concerns are, and also just how do we get more education about RMOC. So the only other thing we wanted to touch on today was committee vice chair nomination. So I'm being told that the Trauma Commission would like for all of the committees to have not only a chair, but also a vice chair. And we've not had that in this committee. So we would like to take this opportunity to take any nominations for committee vice chair. Now, is there a standard job description for what committee vice chairs will be doing? Liz, I should have asked that before we put this on the agenda.
Yeah, that's a really good question, and we probably should develop that. Thank you. Thank you for asking, Dr. Walker. It's pretty much to be your color commentator and, chair the meetings if you are unable to attend for whatever reason, just to ensure that we have some redundancy with each of the committees and some sort of succession planning.
Right. So speak more about the succession planning. See how she threw that in at the end? She just threw succession planning in at the end. Talk more about succession planning. If this person decides, sure, I'll be vice chair, does that mean that they are next in line to chair the committee?
Well, we would love that. It doesn't always work that cleanly. So I think right now it's the biggest thing, especially for this group. As you know, this group's been through a lot of different changes over the years. It would be great to just have that healthy redundancy built in. It doesn't necessarily have to be the person that, succeeds you. But it would be nice if we could build that in, if possible.
Okay. So let's think about it. Unless someone is chomping at the bit today, I certainly would welcome a vice chair. I try to make this a priority, but we all know life happens, and sometimes it'd be great to have a backup and a colleague to work with. Certainly, if we go down the route of treating this like a succession plan, then I would involve the vice chair in our pre-agenda meetings, which can be as formal as an actual meeting and as informal as a series of emails. So I would include you in all of those activities, how I develop the document that has to go to the Trauma Commission. So if you have some concerns about, I don't know about being the chair, then I certainly would make sure that you would be prepared to do, it's not a heavy lift at all. But you would be prepared whenever my term ends, which are the terms 1 year terms? Where are we in the grand?
No, it's actually 3 terms of 2 years, so maximum 2 terms of 3 years.
Yeah,
it's 6
years.
years total is the maximum. So yeah, and you did have one Dwayne Mitchell from Wellstar. Dwayne, I can't remember which Wellstar organization you're from.
Spalding.
Okay, so that would complement you nicely because that is a level 4. So it would be nice. Well, the structure that we tried to do before was to have vice chairs from the various levels of center. I'm not sure we need to have one per level of center, but it would be nice to have someone who's a vice chair who's not necessarily from one of the academic or bigger centers.
I certainly don't have a problem with that. Dwayne, thank you for that. Do we need an official vote? Do we want to send something out? How official does this need to be? Are we just doing nominations today?
Yeah, we can just do nominations today. So if anyone else is interested, they can feel free to email Dr. Walker, and you can CC GTC Business Ops and myself. That'd be the easiest thing.
Okay. Well, we will, let's probably send something out then, just about the vice chair. I mean, I know it's going to be in the minutes, but we might need to send something out separately about that, so we can make sure everyone sees it and understands the ask. But we've got you down, Dwayne. Thank you very much. All right, so summary actions, important dates. Again, the February 19th is the Georgia Trauma Commission meeting, and that same day is also the Trauma Medical Director meeting. February 24th is Trauma Awareness Day at the Capitol. I always enjoy that day at the Capitol, so hopefully I can make my way up there. And then May 4th is our next Trauma Administrators Committee meeting, and that's the one that is tied to performance-based pay funding. In between then and now, certainly keep on the lookout for some email communication, particularly as we look into perhaps standing up these work groups or subcommittees around RMOC planning. So we will be reaching out when we have more details about that. And Randy Smith also has potential interest as vice chair. So thank you. We've got you down, Randy. Randy, what facility are you representing?
SCMC Health in Valdosta.
Valdosta.
Oh, South Georgia. Yeah. Thank you, Randy.
Okay, does anyone else have any questions, comments before we adjourn? I'll give you a few minutes of your lives back today. Thank you. If you didn't get a chance to sign in at the beginning of the meeting, we've put the QR code. Please make sure you take a minute to do that. Otherwise, thank you for attending, and meeting is adjourned.
Thanks, Dr. Walker.
Thank you. Have a great day, everybody.
Thank you.
Siri, call Emily Brown.